Everyone's having a good night. We're going to talk this evening about document. That's a lot of dental sleep, what's maybe slightly different than in your dental practices. So we hope that this will be beneficial for those of you getting involved, and even those of you who are highly involved in dental sleep. You always have to think about what we're doing a little bit differently than we do in dentistry. Hello, I'm Dr. Guy Yatros. I'm the guy on the left side of your screen.
And I'm Dr. Rich Drake. Thanks for spending part of your evening with us. Hope everybody's doing well, having a good week. And Guy, maybe you should have titled this document, right? It seems like that's what I do in my office, man. I'm always typing stuff. Yep. So I'm looking forward to seeing some of this stuff. So let's get started.
Yeah, we've been doing this a long time, and we hope to help you in your practices. If you want CE credit for this, then make sure you check your email, and you will have CE in the next 48 hours. If you don't see it, please check your spam or junk folder, because we will send that out within 48 hours of tonight. And also, just a reminder, we do these every couple of weeks or so, about every 2 weeks, but the next one's March 13th. We're going to talk about managing side effects of dental devices, and that's always a big topic. I think it's something that dentists maybe are afraid to get involved in dental sleep because of the side effects, but it's once you understand what to do and what to expect, and let your patients know what to expect. These side effects really should not be a reason for dentists to steer away from dental sleep. So we'll hopefully make you feel a lot better about how you manage those in a couple of weeks. Also, just we'll put this up at the end. We do courses all over the country. We've got quite a few coming up, one in Syracuse in a couple of weeks. We do a 2-day hands-on course where you get to actually deliver a device, you get a sleep test, we make a repositioner, so you leave at the end of the course with a real firm understanding of dental sleep and really comfortable going back to starting in your practices. And we do that at very reasonable, including the sleep test and a dental device for just under $1,000. But for those of you attending the course tonight, if you just type in course, and even if you don't see a town that's near you or that you want to go, we're always adding. If you'll type that in, we'll hook you up with $200 off on one of our courses in the future. So
I'm sorry, checking my earphone. Did you say $200 off?
That's what you were doing. I thought you were having a convulsion or something there, but yeah, $200. So down to right at $800, including 2 days of CE. We even take you to dinner on Friday night, so it's about the best deal going in dental sleep. And I can tell you, if you want to learn more about this, you won't find a more better utilization of your time, because we really get to the point. I think that's what we at Dental Sleep Solutions care about. We get up every morning hoping to help dentists who want to get involved in dental sleep to help make it easier, because Rich and I have been doing this for pushing 20 years each, so 35, 40 years between us, and we've learned a lot about how to get through the frustrations. And we'll do other webinars in the future. And if when we talk about dental sleep, we keep coming back to what we call our 4 pillars, which are screening, testing, treating, and billing. If you have systems and team members who are involved in helping you accomplish those, what we call pillars of those goals, dental sleep can become fairly easy and routine as you get your steps in place. You get your team members trained, and we can talk about how we can help train your team members as well. We can go through these steps that used to take me several hours of my time, if not longer, in the dental practice, and under an hour, and at the same time delivering quality care to our patients and helping improve their lives and save their lives while we make more money for our practices. So if you're interested in learning more about that along the way, we'll talk a little bit more towards the end, but we'll be happy to help you. If you just even have a challenge in your office, just type in consultation anytime tonight, and we'll be happy to set you up with one of our member support experts who know all about dental sleep, and they can talk to you about your challenges. So, all right, we're talking about documentation, Rich, but why do we have a picture of the beach out behind my house here?
Yeah, it looks like the sand out there behind your house. That's pretty cool sand you got out there. I think this is one of the hardest things, I think, Guy, for people who are getting into this, is you gotta have this shift in your mind. You're going from dentistry to medicine. We really have a dental solution for a medical diagnosis and problem, and it requires that we think about it differently, that we practice it a little bit differently. our expectations should be different. I think you said it, Guy, a second ago when you were talking about our next webinar of the side effects. Sometimes why dentists don't do this, because they're scared about that. And you said if you just give the patient a realistic expectation about that, then it really makes a difference. And I think as dentists, if we understand this is just done differently, because it's not the same, it's different than what we do as a dentist every day.
Yeah, and I think it's not any harder. I'm not trying to scare anyone away from this, because in many ways it's easier. It's just different. So what I put a slide together here to talk about the kind of the differences between medical and dental being on the left, obviously. In dentistry, we get to make the diagnosis, and really it's not necessarily required. We don't have to have what we call a diagnosis code to do a DO composite. We don't have to say there's distal to caries and that's some sort of a diagnostic code. And furthermore, if it was required, we as dentists can make the diagnosis. And when we're doing dental sleep, and if you want to bill insurance in particular, our medical insurance we're talking about with dental sleep, you have to have a diagnosis code, usually of apnea, and we cannot make that. So we have to work with our physicians. So that's why it's a little different than just going off and making a crown or doing a root canal. In order to determine if it's covered by insurance, what we usually have to do is submit an X-ray, a radiograph of some sort of documentation like that to our insurance company, and they'll either approve or deny it before we begin treatment. Typically, in medicine, your documentation are your notes, your letters from physicians, your progress notes. It's all paper written notes. They don't hold up an X-ray typically at least for dental sleep and say, oh, that person's airway looks small, let's look at their X-ray, and it's covered. And I think one of the big differences are in dentistry, they either pay it or they don't. And if they don't, you can appeal it. But after you get paid, you're pretty much home free. In medicine, they might pay it, and then they may come back later. Didn't you recently have an audit, Rich?
Sure. Rub some salt in that wound while you have it open, will you? But yes, we did. And was it stressful? I say just a little tiny bit. But, my insurance coordinator, Lydia, she said, Dr. Drake, I have everything. I have everything that we need. We do this in my office exactly how you're going to talk about doing it tonight, Guy. And it's not that it's hard. It's just some of it's a little time consuming. But when you do it right, you can feel good about it. And you can feel very good about it. Doesn't matter who comes and asks for their money back. They're not getting it. That's just what we tell them.
Yep, and if you fill out the paperwork well, then there's no worries about it. And the notes are different. We're used to progress notes. In medicine, we have SOAP notes and other types of notes. And even if you're going to bill into medical insurance, you have a different form than the 1500 form versus the dental form. And I think we do pre-authorizations in dentistry, but we do that to see if they'll pay for it or how much they'll cover. In medicine, it's an actual step where you have to work with oftentimes their primary care to get the procedure pre-authorized. And it really is less to do with money, more to do with actually getting the ball rolling for insurance coverage. So there's just differences, and it's not harder or easier. It's just different. And that's why when you're looking to manage this data and this information, you're going to need a system to organize it. I mean, that's what computer systems do. And the country is really pushing more towards EMRs, electronic medical records, and electronic health records. And, I didn't really know the difference between these. And it's kind of a term that's used simultaneously, but there's a little bit of a difference, as you can see from the definitions on here, that an EMR is more of a narrow view, while EHR is more of a comprehensive report of the patient's overall health. And there are some problems with getting everyone to adhere to these, but that's all in all, if you're going to be doing medical treatments on your patients, this is what the type of documentation system that you should be looking for. And you can read some benefits on here. Rich, do you have anything to add on those?
I always look at that, Guy, as the EMR is what a doctor uses in his office, and an EHR is what the hospital uses. That's kind of how I look at it, because it does have a broader scope, and we have a lot of specialties across that. I think 20 years from now, Guy, that we will have standardized systems where, we can get in and see all of that stuff and have access. I mean, think about with your patients, if you had access do an EHR where you could get in there and you could see every note from every doctor, and that's a very powerful thing for us as healthcare practitioners to have. And you got to start somewhere, and that's where we're started. So we're not there yet, but we encourage you to, get into the realm of digital stuff, because as Guy has this slide up here, I was going to teach a course one day, and I get there and my phone lights up and my first message is, "Hey, Rich, I'm watching your office burn on the news." I'm like, what? But we didn't lose any data, because we use DS3 and it backs up to the cloud every single minute. So all of that patient information, and it was there. So hopefully you're doing the same thing with your information at home.
Yeah, and regardless of how you're going to do this, even if you're going to do this with paper, you've got to be organized. And I think that's the reason dental sleep has been something I've really enjoyed, because I like organizing things. I like making the complicated things less difficult, and it's really not difficult. It's just organizing the data and putting it into areas where we know where to retrieve it, we know where to get it more quickly. Because if you don't, you'll end up with a mound of paperwork that really, when the patient walks in, it might take you hours to navigate to even understand where you are. And the last plug we'll have for the EMRs, in particular DS3, is the reason we developed our own digital format to store this data is because none of the dental softwares really house the information that you need. I mean, we're looking at sleep tests and titration studies and symptoms and some of the things we're going to go into right now, and you've got to have a way to organize that. And whether you do it on paper or you do it in digitally, which is better, here's all the information that you need to manage for one patient for the most part. And we're going to go into these in particular so you know what data you need to collect, because dental sleep is primarily talking to your patients, writing down what you learn, making decisions, and oftentimes the decisions you need to make are from information that come from outside of your office, and you need a place to store that and to be able to refer back to that. So I'm not going to read each of these areas to you, but if you just take a glance at that, you can realize that your current organizational system that you're using in your office, whether it be paper, digital, or Sally, however you're doing this, is probably not going to house this information very readily. You're going to have to adapt your system, and that might be the single biggest challenge dentists have, is they're used to doing things the way they're doing, and having different information organized differently can be a challenge. And by the way, Rich, I see that we're getting questions coming in. I know that you're answering some of those. We have our whole dental sleep expert team answering some of them, so we will get to every one of your questions before the night's over. Either type the answers back in or we'll answer them verbally. So keep them coming. That's fantastic. So I think this is one of the biggest ones that we started with, wasn't it, Rich? Sleep test. That to me was, what do I do with this 5-6 pages of this information? Now I've got 3 of these tests sometimes to look at after we've been treating them, and this information.
15 or 20 pages, some of these sleep studies we get, it's like, gosh, dang, but you're right. How do you organize that? You don't have to have an electronic system to do this. You don't have to have an EMR, but you have to be really, really organized. We just try to make it easier to look at and see. So, what's important when you look at that? Well, how old is the sleep test? What kind of test was it? Was it at home or was it in the lab? Where was it done? We like to track some of that kind of stuff. Was a diagnosis made? What's AHI, RDI, supine? So we have all of these things that we're trying to do. We try to put that into a very simple system where you just click, 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 and you put that stuff in. You can scan the sleep study in and upload it as an image, and now we're done with it. We're off to the next thing.
Yeah, and again, we're talking about documentation, and I think maybe when you logged on, it's not all what we write down here. We have to have a copy of the sleep study, whether it was done maybe at the primary care or at a sleep physician, PSG, however it was done. We have to have a copy of that, and furthermore, we have to understand what that says and how it relates to the patient. So documentation for dental sleep is not just what you're documenting. It's getting all the documentation from that pertains to that patient, and as it relates to their airway and how we're going to treat them. And so when we treat patients for sleep apnea, when we're trying to help them, I always ask, I think Rich had you said to your patient, if I could do one thing this dental device or CPAP, if I could just do one thing, what would you want that to be? And it really usually will fall into one of two categories. Either it falls into they want to not die in their sleep, or they want to be healthier. They basically want their apnea better because they know that it's bad.
How negatively it affects their health.
Right. And I'll back up the slide. We can tell that from this first piece of documentation. If it's 15 pages long and I've got 6 patients waiting on me and I don't have this information boiled down to the nuts and bolts we have here, which this is really important. Rich and I spent hours trying to figure out what is this the perfect amount of information you need. It's right here on your screen for free for you folks. If you have that in front of you that quickly, if that's what the patient cares about, if they say, I don't want to die in my sleep, my brother had a heart attack, or I just had heart surgery, something related to their health, we can know by looking at this, really how this apnea plays into it by how bad it is. The other reason that they may say would be something along the lines of, my wife's here because I snore and I'm tired of her waking me up all night, or I wake up exhausted, or I wake up 100 times a night, or I just don't feel refreshed, or all those. We put that as subjective reasons, symptoms. There's the apnea itself is causing negative lifestyle problems. And so before we even talk to our patient as we go along, we need to document this. So we want to grab this information ideally through questionnaires prior to the patient coming in. And we do it really slickly through the health through our web portal, and we divide it into 3 categories. One are their symptoms. The second part is, what have they tried for this before? And we're going to go through each of these with information that you all can grab from your patients and ask. And then, what's your health history? Because we want to make sure we know how that relates to the sleep study and so forth. So if they have AFib or things like that. So we want to grab this information from the patient, but if we can get it from them before they come in, and we have that in an organized manner before we actually see the patient and walk through that door, and we know what their sleep study is, we know a whole lot about that patient. We haven't even said hi to them yet. So let's break this down in the symptoms first.
Let me add one thing to that too,
Sure.
Guy, because you're talking about, well, I'm getting all of this information from the patient that helps me make that decision. But as Dr. Carstensen said, Steve put on a wonderful lecture at our symposium just a few weeks ago about documenting, the medical necessity for this. We're also establishing medical necessity by getting and gathering all of that information as well.
Yeah, of course, which is going to help us.
Get paid.
It's going to help us get paid and to document the proper treatment as the best as a standard of care and so forth. So absolutely, it's to help us decide. It's help us to document. It's help us to get our patients paid. So as far as symptoms go, Rich and I literally had hours of we could call them conversations or arguments, depending on if you were talking to us or our wives sitting around listening to us bicker about what it is we want to ask each of our patients. So we tried to distill that down into some really the most important and common questions, and it literally took us days to figure out, probably longer than days. We tried it and we came back, and there's other information you may want to gather, but on all of our patients, this is the symptoms that we kind of we want to know before the patient begins treatment. Also, we're going to look at these same things after we begin treatment too, so that we can see how well we've done. So the first one, I think almost everybody knows, Epworth sleepiness scale. Don't have a whole lot of time to explain it, other than it just is a real common.
How sleepy
scale.
are you? Yeah, during times when you really want to stay awake. There's also the Stop Bang and the Berlin questionnaire. It's kind of like VHS and Beta. We had to choose one. We chose one. We may add others at some point, but that's what we have.
Right, and it just gives you 0 to 24, and it's really commonly used in the medical offices, so that's one of the reasons we chose it. Well, maybe not as common as that, but we're friends with Keith Thornton, and who invented the TAP, and he came up with a kind of a snoring scale similar to the Epworth, and we use that on each of our patients to really see how their snoring is. And it's a 0 to 15 scale, ideally asked with the bedtime partner present about their snoring, and we'll get a score that we can see if it's above 5 that we know that it might be bothersome to the patient. And then I think this blank box here is probably the most important. I left it blank on the slide because the patient will fill this out on the web portal. They send it to us, and with the click of a button, and we have it. But a lot of times they really won't put what I want there. They'll put, I hate my CPAP, or my wife hates me. I don't know, different things like that. But what I want to really know is what the number one thing, like Rich says, what is the one reason, if I could fix one thing, what would it be? And so sometimes you have to clarify that. That's why I left it blank to remind us that whatever they put there, let's go back and make sure that's their really truly motivating factor to be treated. And then there's a lot of other things that we ask that they may not be thinking about that's could be related to airway problems.
Yeah, that's what I like about our system, Guy, when we do that. And we did have some discussions about what we put on there. If we wanted to make this all encompassing for every single doctor and dentist out there, it would be 5 million pages long. So, but we try to boil it down to what's important. This is how we establish the need, the medical necessity. And like you said, Guy, sometimes this will spawn somebody to go, you know what, I do have dry mouth in the morning, or I do get headaches, and they hadn't thought of that. And then they check these boxes, and these show up in a very organized form for us to look at. And again, Guy is the king at organizing stuff, and a lot of the software is built this way that I use just because it makes it a lot easier.
And then these are the symptoms that we agreed upon that we're going to collect on each patient. And again, we'll talk to our patient. Rich's favorite saying, you got to use your brain. There's other things that they may tell us that are pertinent. But if we can come up with a system that each time we ask them the same questions, that way after we treat them, we can see how we're doing. And we talk about energy level, sleep quality, because sometimes people aren't sleepy. They're not falling asleep during movies or while they're driving, but they're just tired and fatigued. We ask them about snoring. We also have a snoring scale on 0 to 10, which gives us some different information than a Thornton at times, and how many times they wake up, and how much they sleep at night, how many hours, headaches in the morning, if they have a bedtime partner, are they sleeping in the same room? And Rich and I actually argued or discussed over the line. I won that one, but he was going to ask him, do you want them to sleep in the same room, was going to be the line. Right next to the bottom, but I thought we didn't necessarily need that one. Plus, if we asked that and the answer was no, then we might go down a path we don't really want to find ourselves on. So we neglected to put that one in there, but after I talked Rich out of it. But how many times a night does your partner notice you having an apnea or quit breathing? So, there's other questions. Some of you may be saying, I asked this or that, and that's great. But what we ask you to do is to have a system to where you're documenting both the sleep study information and the patient's symptoms the same way on each patient. And it will make you be consistent. It'll make your follow-ups consistent. It'll make your team consistent. And again, there's things that don't fall into this box, but we'll add those in the progress notes as needed. And then once we know their symptoms, we want to know what else they've tried. What else have you done for your snoring or your sleep apnea? And I think the most common one is, have you worn a CPAP? But you know how many times, Rich, I see that's the only thing they ask is, have you tried CPAP? Yes or no? Are you wearing it? Yes or no? Well, that's not good enough, because Rich and I had that originally on our questionnaires, and we want to know how much they're wearing it. I mean, if the guy's only wearing it 3 nights a week, 4 hours a night, and their AHI is 75, I'm going to make them a dental device as quick as possible. As opposed to 7 days a week, 8 hours a night, and they just had a stroke and their spouse is an attorney, I might just want to leave them alone. I mean, there's that information's pretty important that we have there. And then also we want to know. Go ahead.
We also use this for insurance purposes as well, Guy, because we're documenting the patient's CPAP intolerance. This is why I can't use it. It's not good enough that a patient just says, well, I don't use it. Well, right. Why? What kind of problems did you have? And it's not hard to come up with more. You could probably make this list as long as your leg too, Guy, if you wanted to, but it's good enough.
But, the other reason we document why they can't wear it is sometimes that may give us a clue as to whether they'll be able to wear a dental device.
That's true.
Some of the things that are on there may make you you may not wear a dental device either. And then the other thing is oftentimes we do combination therapy where they wear a dental device and CPAP. And if their chief complaint is claustrophobia, I think wearing both of these is probably going to make them worse, But if it's the pressure or other things, then maybe we'll glean some information about treatment. So again, it does seem like a lot of paperwork when we ask our patients this, but it's all absolutely necessary for us to document it properly, medically, legally, get patients coverage, and for us to really make proper medical decisions. We ask them about other treatments too. We're in a dental device. I used to just ask them that and left it alone. We didn't get into this, is it over the counter? What was your experience with it? And boy, I'm glad I asked these questions now, because sometimes you may think that twice about making someone a dental device depending on how they answer these.
Yeah, and there's a lot of marketing going on out there, Guy, for, over-the-counter devices. I always look at this, Guy, as, I don't look at, if you try an over-the-counter device and you fail, I don't look at that as a negative. If you try an over-the-counter device and you have any bit of success with it, I look at that as a very positive, because the one I'm going to make you is going to fit a whole lot better. It's going to stay in a whole lot better, and it's a lot more adjustable. So again, this is using your brain with all of this stuff. We're just trying to organize this into a very standard every single time somebody comes in. Now, you're going to have 3 or 4 other questions that you're going to want to add, and Guy's going to show you where we put those in the progress note and how we document that stuff at some point. But all of this is being done by the patient on a portal in my office, and I just click a couple of buttons and it's all there. It's really nice. I don't have to sit there and go through every single one of these things.
And to be clear, they're doing it at their house or wherever they get their email, and then they click a button and then it arrives at your office instantaneously. So they're not even in your office. And I'll even throw this one in for this, Rich. This may affect insurance as well, because if they had a dental device made a year ago in their Medicare, they may not get coverage for that. So, because they may only cover one every 5 years, depending on what type medical coverage. So all this information is important. Have they tried surgeries? We want to know that as well. That can affect various treatments. It can affect getting coverage, and it's the knowledge that we need to have. And then other attempts, weight loss, Provents, whatever else they may put there, we want to know about. So once we've completed all this, we want a health history. You all know what a health history is, but I will mention, a lot of people will say, well, I have a health history in my dental practice software, and that's fine. But I'm a big believer, we're big believers in that your medical record should be a standalone record. This is a medical chart, your dental chart's a dental chart. And even if you're using paper charts, whatever form you're using, you should have a separate health history for your patient's medical chart. When I used paper years ago, and I had a patient who was my dental patient and my sleep patient, they had 2 charts in my practice. One was their dental sleep chart and one was their dental chart. And so you still need a health history to be part of this, and even a dental and family history, which certainly for Rich and I, who just see patients for APME, we don't have a dental practice. This is really important, because sometimes they come in and everything's looking great until I look here and they say their teeth are, in bad condition. And we may want to, before we even start talking to the patient about dental sleep therapy, we may want to take a quick look in their mouth to see if they even qualify. So there's kind of a quick review of the symptoms that we're going to grab, ask from the patients and get our information. And then once we have that, we're going to continue to gather this information from our patients as we treat them down the road and see how well our treatments are going.
That's a lot of stuff you went over there, Guy. It really is. That's an unbelievable amount of information that we're collecting that not only helps make us better practitioners, it makes our treatment more successful. You've said several times, Guy, well, this may be a clue for I don't want to treat this patient, or I do want to, or how I want to do it. So that's all important.
Yeah. So if we're going to, the patient comes in, they've got all this information, we're going to do an exam, and we're going to go into that and tell you what information you want to gather on your patients. It's different from your dental exam. I do want to mention that a lot of people on here asking questions. If we don't get your questions fully answered, that's what we do at DS3. We feel that if you have a system for screening, testing, treating, and billing, that you'll be successful. And how we help is through education, coaching, software, and support. And we have just a room full of dental sleep experts that can help you. And if we can't get to your questions completely tonight, just type in consultation or consult, and we'll schedule time just to talk to you about your dental sleep challenges. And I promise you'll find that time to be worthwhile. And we'll answer your questions or find a way to navigate through your challenges. So we're going to do the exam on our patient now that they've gathered all that other information. But I think an important piece of documentation we certainly want before we begin treatment are these two pieces: the informed consent. I think most dentists are familiar with that. Wouldn't you think, Rich, what they are? I don't think we need
Yeah. And we have these built into our system. The dental device manufacturers and the labs have samples of these that they will send you as well if you're just looking for some place to start.
Mm-hmm. And the AADSM has one if you're a member for them. So it's pretty much, it just says basically that that you've been informed of your treatment options and they consent to the treatment after they've weighed the risk benefits and alternatives of treatment. That's what it should say to some extent. Now this form, I don't think most of you are likely familiar with unless you're already doing dental sleep. And I didn't really understand this form at first. Ken Burley, I talked to him a little bit at our symposium a couple weeks ago, and he was kind enough to help us with one of these forms, and I think he's got a new one he's going to get to us. I think he's actually speaking at our symposium next year as well. He's an attorney who's a dentist, and what his point when he explained what this was to me in layman's term is, you've got a patient who has a medical condition, and that medical condition may cause them to have a problem. They could be in a car wreck. They could be in a car wreck and hurt somebody else. They could have a heart attack. A lot of things can happen because you have apnea. And it needs to be understood that if those things happen, that it's not because of your treatment, it's because of their apnea. And we can't be held to the level of, if that happens, it's our fault, basically. So what this form basically says is that if the symptoms of apnea, the results of apnea happen, the patient's releasing us from liability for that because it's a condition they already had when they walked through the door, and they're releasing us from liability. Did I explain that as well enough, or Richard?
Yeah.
Do you have anything?
No, that's good.
Yeah.
It's a little. Is it too much? Well, can you ever have too much? In some sense. So we want to protect ourselves. We don't want to scare you in any sense, in any way, from doing this. Do we think you should be doing this as a dentist? Absolutely. I mean, we've spent last 10 years of our lives, Guy, 20 hours a day trying to get dentists to do this more and all that stuff. So just use your brain, be smart about it. We have these things, they're out there, and
I've never had a patient who wouldn't sign it. I've had patients that had questions. We explain what it's for, and it's never been a hurdle that prevented them from going forward with treatment. So just another thing to document, because that's what we're talking about tonight. For your patients. So once we get the form signed and we're going to begin treatment, we're going to start with a dental exam. And I'm not going to spend any time on this. It's basically we need to look at their teeth and see if their teeth are strong enough to hold a dental device. And you can chart open contacts and the occlusion and missing teeth, and certainly want to do a periodontal charting of some sort. And we'll leave that to you, dentists, but understand, just put a different hat on and say, I want to look at these teeth and see if there's enough teeth that are spaced out evenly enough to where I can anchor this device to it. And we need to document that. We have check boxes to make that easier. Now, I think as we go into the mouth and we look at the teeth, we start looking at the airway and the tissues and things that, to me, what I try to get out of this, Rich, is two things. One, I want to document things, document the tissues in such a way that if they might affect the airway, we want to note that. And then I also want to look at things that might affect my device design. If they have big tori, or their bite could affect that, or the shape of their teeth, the things that could affect which device I might use and whether it would work or not. Tongue size that you might want to think about, which we're going to get into in a minute. So those are really the two things I'm looking for. I want to document the airway and the tissues, how it might affect that, and then also I want to document my justification of the device that we're going to kind of steer the patient towards. So tonsils are, typically they don't look like the grade 4 here on the right, but if they do, well, surely goodness, we want to document that and let them know that may be a problem that a dental device may not overcome, and we may want to talk to them about seeing an ENT down the road if indicated.
Yeah, well, maybe we should rename that pharyngeal grading. There's different ways that people look at that and see that, but you got to look down the back of their throat. How big's their tongue? Is it scalloped? Is their arch narrow? I mean, how well can they breathe through their nose? We're trying to do all of this stuff. We've just given you a way to do it. You can't make it any more simple than boxes with pictures and a checkbox, can you? I mean, I love that. We've tried to make this as simple as you can do. And I know, Guy, you've said this in your office. You have, the assistant sitting there, and you taught me how to do that. She's walking through, okay, airway, tonsils, grade 1, maxillary arch, vaulted, narrow. She's just walking us right through that. And we've got it down under 5 minutes now. So
absolutely. And Mountain Patty is something, if you don't know what it is, maybe just Google it, because I don't want to spend the 3 minutes it would take to explain it, but it's just a way of looking at the airway that was developed by an anesthesiologist, and you can just look at the pictures and pick the one it looks like. And obviously, the further to the right you go, the more likely they are to have a problem. And here's where Rich is talking about. We look at the upper and the lower arches. What shape are they? Do they have tori? Do they have exostosis? Are they narrow? All the things that might affect their airway and our device choice. And the soft palate, we look at it, the uvula. Is it elongated? Is it beaten up? Looks like what we call battered or edematous, or does it look like it's hanging in their airway too? The gag reflex. And Rich, you taught me this, the nose. Man, I think that's real important.
Special test?
Yeah, you want to show them the test?
Okay. Let me see how plug up one side. Let me see how you breathe. Plug up the other side. So make sure they're breathing in, Guy, not breathing out. If you're sitting real close to them, I learned that the other day the hard way.
Because it'll
something. Yeah, like
seriously. well, also if they have a real flexible nasal valve, it'll close off when they breathe in, but not when they breathe out. So you just want to assess where they can breathe through their nose, and we could probably do a whole webinar on what you do when they can't breathe through their nose. But if they can't breathe through their nose, it could negatively affect both CPAP and dental device treatments, which are the two treatments for sleep apnea that are first line of therapy. So it's important to know and to talk about and make appropriate referrals if needed for those type things. And then we want to do look at their jaws and muscles, and we have some muscles on here. We have an advanced TMD module coming out in the second quarter of this year, and there's muscles on there. I don't even know what they mean. So it's up to you which muscles you like and do. But I think suffice it to say, we want to see if they have a muscular problem or a joint problem prior to we beginning treatment. We're going to document this, and then in most cases we're just documenting, and it's even if there are some issues, we're talking about it, letting them know it could affect things. But for the most part, we're probably going to go forward with treatment, even if we find these type things. If you have concerns about that, back in one of our Dental Sleep Medicine Insider articles, Jameson Spencer, who's just brilliant individual and can really explain things better than I ever thought about, did a really good article we can direct you to about popping joints and what that means to dental sleep. And I think he said it better than anybody ever has. So most of the time these don't prevent us from beginning treatment, but it is certainly something we need to document.
Mostly, if nothing for anything else, Guy, I know you're on track here and you don't like me to get too far off schedule here, but
we're good. We're doing okay.
Okay. Somebody goes, well, look, since I started wearing your device, my jaw pops. And first thing I do, I pull up their progress note. I go to that and I go, yes. Well, it's funny, 3 months ago, I put in here, your jaw occasionally clicks or pops, so it's good practice.
And we always mention it to them when they do it. So you got a clicking joint, and I explain to them what that means. At that time, they don't always remember that conversation is what you're telling me, it sounds like. But make sure you document it. You're absolutely right. And occasionally it didn't pop before. And that's okay. I mean, we'll talk about that. I don't act alarmed. That's the number one thing. We don't, if you're doing surgery, you never say, where's all that blood coming from? Big eyes like this. No, act like it's okay. It's going to be fine. So same thing here. If they come in, they got a clicking joint. We'll hey, this is a good subject for next webinar. As a matter of fact, we're talking about that. So we'll go, if these things are concerning to you, we'll make you at ease with that in a few weeks when we do the side effects. For the most part, it's not an issue. But what we for sure need to do is measure the range of motion. I think it's probably more important than all those other things. We want to know how wide they can open, because that could affect which device we're going to do. It can also tell us a little bit about what's going on in their joint. And for sure, we want to know how far they can move their jaw back and forth. And you can do that with various gauges, George gauge, pro gauges. SomnoMed's got a gauge now. Drake, are you going to make a gauge? We're going to have a Drake gauge one day, maybe? I don't know. We can probably invent that too. But
our spare time, we'll come up with that. Holy God.
I do probably not necessary because there's plenty out there to do it. We're just going to airway metrics is another one. We want to measure from their jaw forward and back, and we call it negative to the back, positive to the front. And we'll get a range of motion, and that could certainly affect where we start the device, and also
it affects a lot of things, like you said, Guy. Which device we make, some people, their jaws are so tight and their muscles are so bad. We don't do this a lot, one time a year, but we might put them in an NTI just so we can get their mouth open far enough to take an impression or do scans. So again, you got to use your brain, and these are all great things to.
We've got to document this, because once we start treatment, I can tell you why I know it's important, because in the past it wasn't documented in my office at times. Then we go back, where did we start this patient? What was their range of motion before? Did they have a click before? Was their mouth only opening 30 millimeters when they came in here? And now it is. I'd like to know that, wouldn't we? When they come in. So it's really important to document all these things, range of motion at the beginning of treatment. And then as we go forward with our titration of devices, we want to have a place to document how far forward we're moving their jaw. And it's kind of hard to go backwards and grab that information after you've already began treatment. So I think one of the things we do, I'm probably the most proud of our summary sheet and the system we put together, Rich. This is Rich's patient, Pat. I think some of you can remember. It's Pat from Saturday Night Live, in case some of you are younger than us. But it's a joke, so in other words. But the page is not a joke. This page is extremely important. We don't have time to show you all the tabs down the left side there where you can just go. But a click of a button, we can know all this information we've talked about up until now. With a click of a button, it can be displayed like that. So in a matter of a minute, if a patient comes in my office and I haven't seen them in 6 months, I can know what their symptoms were, how they've progressed on their symptoms, what their sleep test studies were, how their AHI improved, how their oxygen improved, whether they have a bedtime partner, whether they're in the room or not, what insurance coverage they have.
Yeah, it just goes on and on and on and on and on.
It's all in the medical history. Consolidated.
This is where I live my life, Guy, right on this page, just day in, day out.
And we can do it in a minute. You can do it with paper charts, but all that information I just listed is probably in the neighborhood of 15, 20 pages on average, if not longer. And so if we look at all that information, you're going to get frustrated because you're going to be flipping back and forth. So find a system that consolidates all that information, because we honestly haven't gone over anything that was excessive so far. Everything we've talked about is important to document on literally every patient you're going to treat. There's actually more to it than that in some cases. That's really the minimum you want. So you need a system to make that, and we can certainly help you with that system if you want. So just to give you a quick look at how you do that with the symptoms, this is the subjective symptoms as the patient first came in the office, and you can see we have abbreviations for Epworth and the snoring and the things that we talked about. And then if they come in for the next appointment, we can quickly at a glance know that they became less sleepy, less snory, that their sleep quality's gotten better. And I can see that just like that. My team can see it just like that. I can see that 6 months from now when they come in, I've forgotten all about what's going on in this patient without having to go back and look at 15, 20 pages worth of information. Same thing with the sleep studies. If you have a way to go from your baseline here, and then we've had 3 follow-up sleep studies, we can see they've gradually gotten better. If you don't know what AHI is, that's another course. But basically, that's how many times they quit breathing at night. And wow, it's gone from 30 down to 6 over the last course of these sleep studies, and their oxygen levels have improved. And so we can very quickly see that. And if we really wanted the more detail, then we can review the whole sleep study information, and by hitting view, and it'll give us the full 2, 3, 5, 10 pages if for some reason we wanted to see that. So you have to have a system to document what you do, as well as the other information that comes from your other medical healthcare providers that you're working with. And if you don't have that, you're going to end up very possibly being frustrated. Okay, that's the system. Let's talk about insurance for a minute. Rich, you love insurance, right? Medical insurance is your favorite thing to talk about?
Makes my blood pressure go up a little bit every time I hear that word, insurance. What do you got to have to file a claim? You need to have some of these things. This is all what Guy's been talking about. all night. You got to have a copy of that sleep test. Do they have a diagnosis? Remember, we've gone through each one of these things. You have that questionnaire. What does that questionnaire do? It establishes medical necessity. It does a lot of these things. We have our notes. If we need a affidavit for CPAP intolerance, we need to know what insurance is going to pay, guy, because every one of my patients asks the same question. How much does it cost? What does my insurance pay? We got to have that prescription. We gave up calling it the letter of medical necessity because we just call it the prescription now at my office. And that's just the doctor saying, hey, I'm referring this patient to Dr. Drake, and this is what we're going to make him. The proof of delivery, that's just a simple form that we have in DS3. It's just saying that we delivered that the patient actually took that. And of course, we have to have a way to submit the claim as well.
Yeah, and we're going to go into each of these a little bit more detail, and then we'll have some time for questions at the end. And I think, one of the things people ask is, well, how much documentation do you need for insurance? And everything we talk about, there's more than just insurance. We've talked about we need it for us to make proper decisions. We need to do it to be the best standards of medical practice and so forth. But within the insurance community, the answer is it depends. Some insurance require this, some require that, some don't require things. And I think the safest thing to do, Rich put together these slides, are if you stick with Medicare guidelines and you have the documentation that they require, and it's not hard to find out. That information's out there. They tell you exactly what you need. So if we're going a little too fast, we can help you with that, or you can look it up. It's written out there in black and white. And if you go by Medicare guidelines for your documentation for doing dental devices in particular, we're talking about, then I think for most insurances you'll probably be okay, and certainly you should be okay medically, legally for most. So what are those? Rich, you're the expert in this subject.
Yeah, remember Medicare is a different beast. It's just its own set of rules out there. And like Guy said, if you follow these, you're covered pretty much all of the time. But as you do more of this and you get to feel, one of the questions, Guy, was, don't we often need a pre-authorization? Yes, very often we do need a pre-authorization, but sometimes we don't. So, but if we take a regular patient away and we say, okay, this is now somebody 65 or older that has Medicare, there's a bunch of pages of this stuff, and we've kind of broken it down. They have to have a face-to-face with the MD. Does telemedicine count? Yes, it does. Okay, in a nutshell, they have to meet certain criteria. So if they have mild sleep apnea, which is 5 to 15, then they have to have a minimum of 10 events. And you have to also document some of the other things like the daytime sleepiness, impaired cognition, the health things. Again, Guy, where does all of this come from? You've been talking about this for the last half an hour. Where all of this stuff comes from. If the AHI is between 15 with a minimum of 30 events, so you see some of that stuff there. So the takeaway from here is Medicare face-to-face, make sure they meet the minimum requirements. And if they are severe, then you have to document that they will not use PAP, or that they've tried to use PAP and they can't use it.
Or the physician says PAP's contraindicated. That's really the take home on that. And so when we're going to code this for medical insurance, as far as documentation goes, you have to have a diagnosis code. In particular, you have to have a diagnosis code of G47.33. You may run across the old code. That's pretty much, if they have the old code, they probably need a new sleep test anyway, because for the most part, they need a test within the last couple of years. And the treatment you're going to use is a DME code of E0486. So that's the codes we use to submit the claim. The modifiers just means that you have all that documentation that we've already previously talked about. So don't they meet the requirements. Don't check that if they don't. That's saying that you've checked it, and they do. And Medicare will cover this about every 5 years. They make exceptions. I've had a patient who got one stolen in Europe, and I think you had one that a dog or something got a hold of, right, Rich, or something that they might make.
You can get them to pay for another one in less than 5 years, but it's not wear and tear. Remember that.
Right. And then Rich already called this the prescription. And, there's a lot of names for this, but there's really two purposes of this. And I think most people think, well, I just have to have this for insurance, which you do. I mean, if you're going to submit to medical insurance, you need something in writing from their, as Rich would say, best physician, the physician that's in charge of their care. We usually say primary care, but sometimes it's not. Maybe it's a cardiologist. Whoever's in charge of telling that, really taking the care of that patient from a day-to-day basis. And it basically needs to say that the things you can see here on the screen, but basically saying that the patient needs a dental device and it's medically necessary for that. And it may even just say RX and have the prescription. And we have some ways of helping you with that by making referral plans that you give to the physician. They can just fill out and send to you. There's a lot of easier ways of doing it, but you really need to have that for insurance. But I don't think that's the only reason you need it. I don't really feel comfortable treating a patient who sees their primary care regularly, or even if they don't, and making them a dental device any more than you should feel comfortable putting an implant in on a patient. If you're a specialist, if you don't talk to the general dentist, that physician is the quarterback, and they deserve to know what's going on with their patient. And if you just willy-nilly go out and do it without talking to them, they may be upset, and they may have a right to be. So I don't think it's just for insurance. It's our way of communicating with the physician that we're all on board with this treatment.
Yeah, you've said a couple of things tonight, Guy, that remind me that we're not an island here. We shouldn't be doing this all alone. You know, we wouldn't manage a patient's blood pressure med. We wouldn't go, what are you on that for? You know, we're going to change that. That's how a physician would see this if we did that without that. They would see that in the same light. So I'm reminded more and more, you know, as I hear you talk tonight, that we're on the same side. We're all trying to, you know, help the patient get treated. So, what do you have here?
Physician.
So, yeah, what I put in here, Guy, the reason I put this was that everything in that patient's medical record has to support what we're doing. It can't, in other words, I can't just say the patient's really sleepy and tired, so it's medically necessary to treat their sleep apnea. That can't be the only note ever that was put about that patient. So there has to be some consistency in this. So again, you got to make sure that the note, and we actually make this for the doctor to sign. We make it easy for him. You can do that same kind of thing. And then, of course, we talked about the proof of delivery before. Here's what you need on this. Again,
just think about this as DME. You know, my mom got oxygen. Yeah, my mom got oxygen because she has COPD. They didn't just throw the tanks in her house and leave. They had her sign something saying she received this. And so, even though we feel we're dentists and this is a dental device, from the medical insurance world, it's a durable medical. It's a crutch or oxygen, and they've got to sign off. You've got to have a proof form that they sign off that they actually received that. I don't know if it's as necessary for people who don't have insurance, but we just do it the same on every patient. That way we have the proper documentation. And the ABN, Advanced Beneficiary Notice, this really only does pertain to Medicare. And if you're a Medicare provider, or even if you're not, this just informs the beneficiary of your Medicare status and what that means to them. And if you have questions about this form, certainly type in consultation. We'll go over that with you. It's more than a 2-minute conversation. And really, it depends on your status with Medicare and what that means to the patient. And it's a form that makes sure that they get that and understand by coming to you, whether you're a provider or whether you're not, and what their expected expenditures might be in your office. So it's a form you certainly should be using if you are doing seeing Medicare patients, even if you're not a Medicare provider. Maybe I should even say, especially if you're not a Medicare provider, you should be filling out that form with the patients. And so again, we can help you with that. So I think, Rich, you put this in as these kind of take-home messages, right? These are something you always need to be thinking about. Yeah.
So who orders the sleep study? Are you comfortable doing that, Guy, as a dentist?
It depends on if they're Medicare or not, but I certainly am in the state of Florida. Yes.
Some states you can't do that. So the answer to that is it depends, right? It depends on which state you practice in, and it depends on your tolerance level for that. I would tell you, simply call your state dental board and ask them, can I order a sleep test? Most of them won't even know. Okay. But that's part of the reason I put that in there is I want you to do a little bit of homework. I want you to help to try to figure this out on your own. In Texas, yes, I'm comfortable doing that. Do I do it as an island? No, I usually will pick up the phone and call the physician. Guy, I've been telling dentists for 20 years to do that, but none of them do it. So
Right.
you at least call your state board and you do that. Can we make the diagnosis? Absolutely not. We can't. We're not saying do that. The physician has to make the diagnosis. The physician writes the prescription. And I think collectively, we all get all of this information that together decides on the medical necessity.
That's perfect. I love the way you said that. It's we get this letter from the physician, but they don't know the patient too. Maybe they're in agreement if they're entrusting us with that decision, but we need to gather their information, whether they believe it's a good treatment, we believe, and we may even be talking to an ENT about their nose before we make a decision. And I love what you just said there. It's not just getting a piece of paper saying, is this medically necessary? We've got to make a decision here. And that's what doctors do. They make decisions. They look at the information and they make decisions. They don't grind on enamel. And they're not carpenters like we are. And so you've got to put a little different mindset, and you get paid for making medical decisions. And you should get paid for doing that. So I think the take home on this is document, document, document. If you don't write it down, it didn't happen. I tell you, that's probably the biggest pet peeve in my office. I go back and I look at a chart. Someone's coming in. Hopefully it's just a regular patient, but sometimes there's someone's have some sort of problem. And what I tell my team is, it's like a book. I should be able to look at that chart, and I should be able to just read it, tell a story, and go through what happened with that patient and why it happened. And it should be as well written that I should know exactly everything that's happened since that patient came into my practice or our lives, and maybe even a lot beforehand that happened because we wanted the history before. We should be. And if you look at your charts and you can't figure that out from reading them, then you're not writing down enough, or you're writing it down in a method that is doesn't flow well, and that you can't access it readily. So it's just that simple. You've got to write this stuff down.
Let me add one more thing to that, Guy. I know
sure.
we got another minute left. One of the things I learned from Dr. Carstensen the other day at the symposium too was, and I've been doing this, but I just didn't know why, was you got to write down what you think about too.
Right. I like that. It was very good.
Yeah. Steve was like, you can get paid for thinking. As
right.
Dentists, we're so used to, we don't get, I used to say, with my kids, they'd ask for some money or something. I go, are my hands in somebody's mouth? Does it look like I'm making money? Because that was the only way I could make money. And now I know, hey, I get paid for thinking. What a wonderful thing, right? So again, you got to write it down though. That shows that you were thinking about it.
Absolutely. Well, again, we'll get to all your questions. We're getting to them right now. So just remember, if you want to do this in your practice, it's as simple or as difficult, depending on how you look at it, as coming up with a system and having team members who can help you screen your patients, get them tested, and then we treat them, and then we need to get paid for it. Now, I mean, it's just that simple. And if you go back to your practice and you're saying, I want to see more patients for dental sleep, something here, you don't have a system, you don't have team members who are trained, you don't have buy-in by your team or something to do each of these, and try to figure out where it's broken. Are you screening and not testing? Are you testing and not treating? Are you wanting to treat but no one's paying you, so you quit doing this? Figure out where that went wrong, and I can promise you can do this in just a very little bit of your doctor time once you have systems in place. And the return on investment, I mean, if you do a device every other week, it can add $40,000 to your pocket. I mean, that's after expenses of paying us, paying third-party billers, paying the lab, and these are very conservative figures. If you do one of these a week and take 4 weeks off, it's pushing 6 figures that you're just going to add to your income. You already paid your other overhead. We're not playing with numbers here. It can add a whole heck of a lot to your bottom line. And so, one of the things that came up at the symposium, Rich, was, what do you all do? What does dental sleep solution. What is DS3? And I think, a lot of people know that we have this EMR cloud-based software. A lot of people know that we help with medical billing, but they don't really. I think one of the common things I got from feedback from people that actually have known us for a little while is, wow, I didn't know you do all that. And I think in a nutshell, what we do is we get up every morning, myself and our whole team of over pushing 24 people here get up, and we help dentists who want to put dental sleep in their practices. We help them with all those hurdles. We help them various ways, and we help them through education and support, yes, through systems like our cloud-based software and insurance billing, but we help them, and we help them with training. And what we do that for is $800 is what we offer that for our for 3 months of training. And most people at the end of 3 months have all the systems in place they need to do this. And we used to require longer term contracts, but what we realize now is that that in 3 months you'll either know you want to do this or you don't. And most people who really want to do this will. It's just a matter of putting the effort forward. And we, in 3 months, we put people through our training program, which are cloud-based, followed up by live go-to-meeting trainings. We have support 5 days a week. We have personalized webinars that we do for the teams. We have group webinars for Study Club for just our members. And again, it's $795 for to start with for 3 months, and it's $99 a month. I forgot to mention that for the first three months as well.
And a lot of people, Guy, are already getting paid, by 90 days.
Well, that's the goal. We get most people get their first check by the end of that 90 days. So if you want to talk more about that, or if you just want to have a question answered, because we're happy just to give away some of our services because we believe in what we're doing. Rich and I started this because we wanted to help people. We want to help dentists succeed. And so if you have a specific question, just type in consultation. One of our team members will get with you and answer that. If you're interested in learning more how for $800 you can get started and get your team going down that path of learning on how to do this. And that's really what we do. Hold your hand all along the way. Just type that in. If you want to come to one of our courses, type that in, as we already mentioned. And then we're going to give you something for free before we leave here. If you're not already subscribed to Dental Sleep Insider, go ahead and do that. You go to dentalsleepinsider.com. Our Dental Sleep Medicine Insider, I think we're on our 26th or something publication. We have another one coming out. It's free. It'll come to your inbox. Your associate, Rich, emailed me today, Dr. Yarborough, hey, Guy, where's that article you did on adding to a dorsal device? And I went back to the November issue of the Insider and clicked on it and sent him the link to it. I usually do a video each month on things like how you repair devices. Rich usually writes articles about insurance or side effects, and it's real practical information that's free. So we like to give back too, and I think over 90,000 people receive that every other month. Again, sign up for it, and you can actually review all the back issues and tons of fantastic information in there for you. So I think there's the courses again, and look at that, we're almost on time here, Rich. That we actually a few of those are changing and we're adding to, so don't put too much into the date. But Rich has a heart attack each time I say, for $795 you get a 2-day course, and it's just a lot of hands-on.
If I'm a dentist and I think I have sleep apnea,
that's worth going just to get that.
Studying a dental device for that much money.
That's true, because
plus all the education.
Yeah, the dental device itself is $300-400 on average, and the sleep test. So yeah, you're absolutely right. So if you think you have apnea, it's worth coming. But we teach you how to do this efficiently in your office. I do most of the courses. Rich does some of them. You will leave saying that was the best day and a half you spent. If you're interested in doing dental sleep, you should really take the time to come to one of our courses. And if you type in course tonight, that'll secure it. I think they keep that for about 6 months or something for you. So side effects coming up. Rich, I'll have to talk to you because I think you just did this at the symposium, so you're going to be leading the charge on that one. But that's going to be a great topic on March 13th. Remember, your CE will come within 40 hours. Check your spam boxes if that doesn't. And here's how you can get a hold of us. I hope that it's been worth your time for staying up on a Tuesday night. We certainly enjoy doing this and helping. I think the symposium, to me, Rich, what was our symposium, for those of you who don't know what we're talking about, we had about 400 attend our annual meeting that we put on every year. It was 2 weeks ago. And to me, the most rewarding thing was when I'm up till midnight at night and gone on the weekends, and my family is like, why are you working so hard? my wife was there at the symposium, and she said, I get it. It was really nice to see the lives we've changed, the dental offices that are helping their patients, and the appreciation. It was just a great time. So we're having one again next year, so we'll have slides in that one probably the next meeting. So
couple of questions, Guy. We'll stay on just a couple more
Sure.
minutes. One was, let's say we screen somebody with the DS screener and they come out as real high risk, plus they've got comorbidities and stuff like that. And the guy says, look, man, I don't want a sleep study. Are you crazy? Just document that. I mean, I don't have them sign anything that says that, but we just document that they're high risk. You got to be careful about how you handle that. I think if you just act like you care about this person, because as you say, Guy, you're the one that taught me, any reasonable person, when you do all of that, would say, oh my gosh, what do I do about that? So when you have that person who says, I'm not doing that, that is not a reasonable person. So yes, document that in their chart. I would document that in DS3. I would also document that in their dental chart, because that's part of your dental visit that day.
Yeah, and let me add something to that, Rich. I agree with everything you said. That's 100%. I don't have them sign something. I mean, I document it, but it rarely happens to me because it scares me. And they see that. I mean, we can't, if you believe in this and you realize that patient maybe not show up for the next appointment because they're not around anymore, when that happens to you, which I know it's happened to you, Rich, and it's happened to me. If you'd have been at the symposium, we had Reggie White's widow speak. Reggie White, for those of you who know, he died of sleep apnea and football player. And if you listen to her talk for 15 minutes, I'll bet it would make you a little bit more inclined to get that person to have a sleep test. So part of it, I'm not pointing fingers at the dentist who asked the question, but I would just ask that you think about how you're going to feel if that patient, you find out they died in their sleep. Would that have made a difference on how you approach that patient? And sometimes our passion and our belief is what needs to be there to get these people to say yes to that. So yes.
Very, very good point. There's another one about how we get documentation from a doctor who we send out. I'm not sure what that is. How do we keep tabs on our patients? Well, I write letters in DS3. I looked up today, Guy, when I left my office, since January 1st, we have put out 936 letters since January 1st. So I am communicating with the doctors. Occasionally, not real often, but occasionally, I will get a letter back that says, hey, thank you so much for keeping me, abreast of what's going on with Guy and his treatment. When we go visit doctors, I have somebody that full-time goes and visits all the doctors and does brochures. She did that today. She came back and she said, Dr. Drake, I just have to tell you, I really enjoy working for you. I said, wow, that's nice. But why? She goes, I went 4 of the 9 doctors' offices that I visited today told me that our office is the best office that they ever deal with. And the only reason is, 1, I bring them donuts occasionally, and 2, I just keep them informed of what's going on. It's 2 or 3 quick sentences. It's not a 12-page letter. And I think even though we don't get that feedback often, I need you dentists out there to understand how important that is, that we do that to the physicians.
Yeah, and the other thing you have to have to me, you have to have a task system. I'm Mr. System, as Rich has pointed out. I'm organized. We have a task system in DS3. So if we need to follow up with a patient in 3 weeks, we assign a task to that patient, associated with that patient rather, and then we assign it to someone. Either myself or one of my team members will call that patient, and we never lose patients because of that. And if the follow-up is to check with the physician to see if they did the follow-up sleep study, we put that down. So you have to have a system for not letting things fall through the cracks. And I did a whole webinar, a whole insider article back in those archives on being organized. And I think that's just a matter of being organized to not let that happen. And you do that along with the letters, and the physicians are going to be really embracing working with you. And it's the right thing to do. That's not the only reason to do it. The patients are getting good treatment. If we
That's
drop
the right thing to do,
our
but
patients,
it also starts to really build on itself, Guy. That's one of the reasons we get a lot of these referrals when we do that. Hey, I have a quick question for you, Guy. How much would you charge me to come out and organize my fishing garage?
Rich was at my house recently, and I just
Yeah, it was
finished
impressive.
finished organizing it from the hurricane. I don't know, Rich. I had to have you walk around with your camera out there and let me see what I'm up against. I need an estimate. I don't know. So it doesn't look real organized behind your head there.
Depends,
So.
right? It depends.
It depends. Yeah, but in my spare time, I'll try to do that for you. So that's funny.
Okay, does Medicare cover a home PS? Well, if it's home, we would then call it a home sleep test as opposed to a polysomnogram. You can actually do a home polysomnogram, but that's a little beyond the scope of this. But yes, absolutely, Medicare. They're the ones that started a lot of this home sleep testing. So again, Medicare's the face-to-face. They got to have that face-to-face. When I asked you, Guy, you've comfortable ordering that sleep test? Not really for Medicare patients because they got to have that face-to-face. So Medicare, push them towards the best MD and get them to do it, but they absolutely pay for it. Yes.
Yeah, they can do it. It's just that basically the requirement is that our physician has to order it. Has to be involved with getting it ordered, but absolutely they can do the home sleep test. And we come to one of our courses, listen to one of our webinars on home sleep testing, and we go in a lot more detail about, even for those patients, we don't just say, oh, can't help you, you're Medicare. No, we don't do that. We work with their primary care. We have forms that we can send to make a process that's repeatable and known by our team members on how to get those patients tested, because they matter too. So we're not going to just drop the ball because they're Medicare. We're going to help them get tested. It's just a little different path that they go down. That's all.
Telemedicine is face-to-face. Yes, they do. There are some stipulations on that, depending on which region you're in, A, B, C, D. But for the most part, yes, they do. I think this is designed especially for people who are in very remote areas. So I'm practicing in a city that has 2 million people, and a guy that lives a mile from my office, that might not qualify. So you got to be careful about this stuff, and you got to use your brain. But, to the best of my knowledge, depending on if they meet certain requirements, Medicare does accept telemedicine as face-to-face.
Yep. And I think that's continuing the change in the right direction. So let's let someone says the connection is terrible. I hear you fine, Rich. I don't know. Do you hear me okay?
Yep. So check your internet. It's probably raining at your house. Sometimes when it rains in my house, it seems like the internet doesn't work well, but we're sorry to hear that. Medicaid, as far as we know, Medicaid does not cover any of this stuff. That is a dental.
Yeah, and we won't even try to answer that because that's state. Each state has different Medicaid. If you're asking Medicare, yes, Medicare does cover Massachusetts. I don't know the amount right off the top of my head. If you want to know the answer to that, set up a consultation or email us, and I do know that information. It's just not, I don't have it memorized. If you're talking about Medicaid, we're not qualified to answer Medicaid because that's different in all 50 states. And from my understanding, I don't know of any states that cover it for apnea, but they probably do, but I don't know about it. So Medicaid is state-run welfare. Medicare is federal health insurance for the retired and disabled. So there's two specific different things. Make sure we're talking about the same things there. I think, has that got most of them, Rich, or where are we? See anything else on those that we didn't answer?
Last one from Dr. Rich. Do we prefer the global fee? I do, Dr.
Yes.
Rich. I mean, there are some dentists on this webinar tonight who do the evaluation and management codes, and they document all that stuff and they bill for it. I don't. I just I know everything that I have to do from start to finish, and I kind of build all of that into my fee, and then we work around it that way. How about you, Guy?
Yeah, and that's what I advise people to do, at least when you get started. Keep it simple. I have a slide for that, but absolutely, there are other ways of doing it, but if you're new to this, certainly keeping it simple.
Start that way. Yeah, keep it simple.
Absolutely. We, if you come to one of our courses, we talk all about the different ways of doing that, and in much more detail. And one thing I'll mention too is a lot of great questions coming in tonight. One of the advantages, if you join DS3, even at the $7.95 introductory offer, we have every other Wednesday. It's myself or Rich. We have webinars that are just for members. There's anywhere from a dozen to 3 or 4 dozen people on there, usually a couple dozen. And we open up the mics. And we, because we don't have, we had 300 people register tonight for this one, so it's a little difficult to do. Everyone who comes to the webinars understands that, and it's just great. It's a big study club meeting where I actually learn something almost every time myself, because we have some really pretty experienced dental sleep dentists and our DS3 members that show up. And so if you like webinars and it's a good way to learn, that's an added benefit that most people really get a lot out of. And those are every other Wednesday night at 8 o'clock Eastern for our members. And even if you're new, you get the full membership with that. So.
Yeah, and Dr. Rich, I will comment on your, in-network. I am in network with several medical payers, and one of them in particular pays me very little, and that's the one that we do bill separately for some of these other codes after that. I feel like if I'm in network and that's all you're going to allow me to charge for the dental device, then I'm going to charge you for every Band-Aid I have to get out of the box, so to speak, But
you also know what they cover on that too, don't you? So it makes it makes the accounting. One of the negatives is if you're out of network billing and you want to bill for each of those appointments, it really becomes more confusing as if it wasn't already. So in network, they'll cover so much for an exam, and you can get a better, more precise idea. And they let you know whether you're allowed to bill for those too, right? Ahead of time.
Yeah, you find out pretty soon if they pay or not. It doesn't take long to figure out. And Stacy, I would just encourage you. One of the things that's kept her from doing it, guys, she says this whole Medicare thing. We get it. I wish I had a nickel for every time I heard that. Don't you, Guy?
Yes.
From a dentist. But we gave you the crash course here on the Medicare thing. Even Steve commented, "Man, those are beautiful slides." It took me hours to put those slides together, Guy, because you got to glean through pages and pages and pages of stuff. But Stacy, that's part of what we do, is we help you do that. Yes, you have to become a DME supplier. Which form is that? It's an 855S. Can you pay somebody to do it? Yes. It doesn't take you very long at all. There is a system and there is a way to do this, and that's what we help you do. So we'll hope you'll take us up on that.
And the last question there, we have one more after it, is do we work with Canadian dentists? I like my favorite answer. It depends, or stay tuned. I had lunch with Brock Rondeau yesterday, who some of you all may know is from Canada, and I've known him for many years, and he's really pushing to make DS3 available there, which we just haven't gone through the steps necessary to make it validated by the Canadian part of what their version of HIPAA would be, even though it's very similar. So you certainly can utilize our other services, and you can access DS3, but we just can't validate it being the Canadian version of HIPAA compliant. So, but I have it on the agenda for the programmers tomorrow to talk about. So we hopefully we'll have a better answer for you than that in the future. Well, there's a long question, Rich. What's that?
Yeah, that's something about somebody's got their own home sleep testing unit, right? They don't bill for it. They kind of use it as a screening thing for Medicare patients. If we did not bill or charge for the sleep study, does it still need to be ordered by an MD, or can a patient do their free sleep study and use the results for the appliance or for Medicare? Remember, Medicare is its own beast, okay? Medicare says that a dentist can't even hook up the sleep test.
Right.
Medicare says you cannot profit from the sleep test and the DME. Now, even though you don't charge for that, it doesn't matter. They say that you can't do that. So with Medicare, don't do that. The short answer is I wouldn't do that. The long answer is call us. Ask for a consultation. If you have a home sleep test, Guy and I and our medical experts, our member service experts, can teach you how to do that with your own device. We can teach you. There are other people out there that you can upload that data to. You can get a board certified doctor to now read that and do that. There are services out there to do that, but it's not a real simple answer. Hey, is that okay, Guy?
That sounds perfect. I'll mention, I'm glad everybody's still on. We're still happy to answer these questions. You do get your CE if you stayed through the first hour. This is a little bit longer than we normally stay on, but Rich, I can't speak for Rich, but I'm happy to continue to answer the questions. I just want anybody to feel like they're not going to get their CE if you have a kid to put to bed or something. So I think we're almost finished anyway. We do get an MD report. I don't know what that means. We do get do you know what that means, Rich?
Which?
The very last one there. I don't know.
Yeah. Well, she's saying when she uses her home sleep testing, she's getting an MD. So, yeah, you may be doing that. You may be doing that. Absolutely right, Dr. Nagy. I hope I said that right. But again, you have to be careful. You got to remember on these webinars, we don't know the level of knowledge that some of these dentists have when they do that. So we have to be careful about what we say. And we also have to say, as a disclaimer, this is February 27th of 2018, because all of this stuff is a moving target. It's changing. I hope a lot of this changes for that makes it easier for us as dentists to do this, and it makes it easier. Guy and I have been trying to push the envelope to lower the barriers, not only for how dentists get into this and do it, but for how patients get into the funnel so that they can get diagnosed and treated. And this is all part of that. Absolutely.
Yep. Well, I think that's it, Rich. So we look forward to having everybody on in a few weeks to talk about side effects. And I think what your title of your program at the symposium was Side Effects, Smart Effects, or I think, is that what it was?
That was Jason's idea. A little pun on the fact that, yes, they happen, we got to get over them. So, but we also know that that's one of the dentist's greatest fears for doing this is, we're going to mess up bites or we're going to change something. So we hope you'll join us in 2 or 3 weeks, whenever it is, Guy. And I promise you're going to learn something from that as well, just like we did tonight.
Absolutely.
And thank you for all your kind words. Everybody who said March that 3rd. March 3rd. Okay.
March 13th.
13th, okay.
Yep. Okay.
And thank you, Guy and Jason, for putting this presentation together. You guys did a fantastic job as always.
Yep. Thank you all. Have a fantastic night. I'm going to shut her down here.
All right.
Good night.